Okay, so good evening once more, and welcome to the last section of the surgery and essential review course that I conducted over the last 3 weeks. Today is the last session so far, and we are going to just complete the rest of colorectal surgery and look at all the important uh, points in this very important subject. So, before we begin, of course, I'm going to again just go through the basic stuff again about the colorectal uh, anatomy, because you see, anatomy is the best way to lay the foundation upon which you can develop your further understanding of colorectal surgery. And the reason why this is important is because we begin with the anatomy, and with each area where we have either tumors, obstructions, peritonitis, perforations, whatever, um, our surgical management changes in the sense that our operative technique will depend on where the tumor is located, like we discussed last time. And it will also depend on, and a lot of the symptoms of these diseases will also depend on where exactly in the colon uh, the disease is. So just as a quick recap, I want all of you to just understand that when you look at the screen in front of you, you will see that this is the anatomy, and it has three sections essentially. One is the ascending colon, then we have the transverse colon, and then the descending colon, which is composed essentially of the descending limb as well as the sigmoid colon, and this is the rectum and anal canal. Now, the reason why we consider the rectum and the anal canal separately is because of the way the fibers or the muscles and the mucosa are arranged, and also because there is a difference in the blood supply along with the nervous supply as well. Now, we'll go into blood supply a little later, but one thing you must remember is that the superior mesenteric artery and the inferior mesenteric artery are the two most important vessels for colorectal surgery. And in specific, when we work out the blood supply section, which will be the next part in this lecture, a lot of the symptoms as well as the presenting complaints will differ based on which artery is being affected as well. So those are particularly important for ischemic disorders of the intestine, right? And here I want to bring your attention to two different parts. One is the right colic or hepatic flexure, and the second is the splenic flexure. Now, the right colic flexure or the hepatic flexure is essentially the flexion point where the ascending colon sort of turns and then joins and becomes the transverse colon. And the splenic flexure is the point where the transverse colon sort of turns again and becomes the descending colon. And this will become more apparent to you when we study resections. We're going to go through the resections again. So the other thing is that I want all of you to also sort of revise or pay attention to layers of the bowel wall. And so when you go from inside to outside, we have the mucosa, the submucosal layer, and then the muscularis layer, and then you have the serosal. And if you take a look at this very good image on the right-hand side of your screen, you will see that the submucosal plexus contains the Meissner's plexus, which is also responsible for a lot of the muscular movements, or rather the peristaltic motion of the bowel wall. And the reason why we need to understand and appreciate the layers of the mucosa is because a lot of the cancers and symptoms that we are going to look at today are very heavily dependent on which layer of the bowel wall they involve, right? And so with that said, I just want you to take one more look at this, and this will be given to you in the presentation as the presentation at the end of the lecture, but it is important for you to know the layers of the bowel wall as well, okay? Now, with that said, let's go on to the blood supply. And this is going to be very, very important, and I have marked it as such on this slide here. A lot of times, from what I've noticed is that blood supply of the colon is a specifically asked question in the interview section, right? And here I want, what I have done is to divide the segments of the intestine with their relevant blood supply. So the ascending colon is supplied by the ileocolic artery as well as the right colic artery, which are direct branches of the superior mesenteric artery, right? So if you see this image here, you see that the superior mesenteric artery is coming down like this, and it has a right colic, middle colic, and ileocolic branch. And for us, the most important part when we look at the ascending colon is the ileocolic and the right colic arteries, right? Second is the transverse colon. And so the transverse colon, if you see it this way here, actually gets one branch from each of this. So right colic and the middle colic artery, and then something from the left colic artery. So the left colic artery, interestingly enough, actually is a branch from the inferior mesenteric artery. So when you look at this transverse colon, and if there are any pathologies surrounding the transverse colon, you are in big trouble, simply because this this segment essentially of the colon receives blood supply from two different major branches of the aorta, right? Then the descending colon, roughly speaking, gets a lot or most of its blood supply from the left colic artery. And if you look at this this image here on the right hand side, you will see that all of these arteries, sort of, they have a lot of collateral blood flow. So what collateral blood flow essentially means is that you have one brain branch and you have these little sort of smaller vessels they form a network essentially that go into the bowel wall here, right? And this is important for two reasons. The first thing is that supposing if you have a blockage or a spasm of any one of these arteries, so for example, the left colic artery itself, you will have, because of collateral blood flow, because of all of this, the damage will be limited to one segment, and it sort of acts as a protective mechanism from preventing the ischemia or infections or whatever from spreading through the rest of the bowel wall, right? Now, the sigmoid colon also has sigmoidal arteries, much like its name, and these are also supplied by the main branch of the inferior mesenteric artery. Now, the high yield point here is the most important thing that you should remember is that there are two main arteries. One is the marginal artery of Drummond. It gives essentially it forms like a collateral blood flow network by taking supplies from the superior mesenteric artery. And this marginal artery of Drummond actually goes this way, right? And if you look at this image here, it's not very precise, my pointer, but if you take a look at this image here, you will see that this is essentially like a side road, and it is giving off multiple smaller roads or smaller vessels that are going to supply the colon. Now, the important bit here is that if, for example, the superior mesenteric artery for some reason is blocked, right? Because of the collateral blood flow passing through the marginal artery of Drummond, you can have a level of perfusion that allows ischemia to take place, but not infarction. And let us just try to revise what the difference between ischemia and infarction is. Ischemia just means that this area has much lower perfusion than is required for metabolic function, whereas infarction is a complete absence of blood flow, which results in tissue necrosis, right? So ischemia happens first, necrosis happens second. So ischemia leads to infarction, which leads to necrosis, right? Now, ischemia can also cause necrosis. There's no denying that. If the metabolic demands are higher than the supply, then you'll have a supply and demand mismatch essentially, which will cause you to have some level of necrosis, right? But the necrosis may not be very aggressive and it may not be very widespread. That's the only difference. And this is also important for one more point, which is that sometimes this marginal artery of Drummond is the one that gets blocked because of atherosclerotic disease, or maybe there's a venous thrombus because the marginal artery of Drummond is also very closely linked with the venous plexus here, right? And because of this, what can happen is that only the hepatic flexure gets ischemic, or it becomes sort of infarcted. And if it's infarcted, then that means you need to sort of remove it, right? It's the same thing with the arc of Riolan. So what the arc of Riolan does is that the arc of Riolan is this artery here, and it is essentially a direct branch between it's a direct connection essentially between the superior and inferior mesenteric artery. Now, the disadvantage here, of course, is that the arc of Riolan is not always present in most people. Like from a retrospective study done a few years ago, they discovered that maybe upwards of 30 to 40% of patients don't actually have the arc of Riolan. So one of the main steps of understanding your preoperative planning for these patients is to try to understand what is the level and depth of the vascular supply that is available to you. So remember that vascular supply is good because although it gives you a lot of challenges to overcome, you need to ensure that you're not transecting the artery or damaging it in any way. But it also allows you to sort of make good decisions about which end or which part of the organ can be well perfused later, right? So that is a major aspect I want all of you to sort of keep in your mind before we go ahead. Okay. Now, when we talk about colorectal disease in and of itself, right, we have a bunch of these diseases here, and we will first begin with intestinal ischemia, and we also have diverticular disease. We have inflammatory bowel disease, polyposis, colon cancer, intestinal obstruction, and megacolon. Right now, here I would like all of you to just take a small step back and try to understand one major idea here. The major idea here is that you look at this thing in yellow called inflammatory bowel disease. Now, inflammatory bowel disease is very different from inflammatory bowel syndrome. Inflammatory bowel syndrome is something that happens only for a fixed amount of time. A lot of people can have IBS, can come and go. It's a slightly different thing from inflammatory bowel disease. Inflammatory bowel disease is a catch-all term for essentially describing two major inflammatory conditions. One is ulcerative colitis, and the second is Crohn's disease, right? Now, this is a very easy topic for you all to read. From a surgical perspective, there's only one thing that matters to us as surgeons, is the fact that inflammatory bowel disease sometimes can be combined with polyposis, and it can increase your risk for colon cancer, right? So those are the three things that I want you to know. Inflammatory bowel disease, especially ulcerative colitis or Crohn's disease, they are surgically important for two things. One is that they can cause polyposis, right? Or they can directly increase the risk of colon cancer, right? And the second thing is that a lot of times patients with inflammatory bowel disease may need certain types of resection. And so when we go towards this discussing all the various surgical operations in our toolkit that is available to us, we will be able to find out, we'll be able to understand and appreciate more deeply why we need to understand inflammatory bowel disease in itself and its implication for the type of surgeries that we can do. Okay. Now, another point I want all of you to understand between intestinal obstruction and megacolon. Intestinal obstruction is the absence essentially of peristaltic movement because there's an outflow and inflow block, right? And this is different from megacolon. So in megacolon, what happens is that the colon widens, right? And then there is a concurrent loss of peristalsis, right? Is different from intestinal obstruction because intestinal obstruction is essentially there is something that is blocking it. In megacolon, that is not always the case, right? You can have megacolon for a lot of different reasons. You can have megacolon simply because of paralysis, right? Or you can have a congenital megacolon in which the Auerbach's plexus or the myenteric plexus is not there. And because of this, there is no peristalsis at all, right? Intestinal obstruction is different because intestinal obstruction occurs because there is a block, right? You have mechanical types and dynamic types, right? And we don't generally call obstructive widening of the intestine as megacolon. Megacolon only occurs when there is a widening or the relaxation of all of the muscles that form the bowel wall, which is not the case with intestinal obstruction, because in intestinal obstruction, just the muscles are getting stretched. They're not relaxed in any way. They are receiving all the impulses that they need to. It's just that those impulses are not effective in any meaningful way, right? So that is the basic idea of the difference between intestinal obstruction and megacolon. Now, I do remember that a few of you had asked if I could mark the important bits in red. And here on this slide, before your exam, whenever it is, I want you to take a small look at this page here, because it is going to give you the three most important things you must know about colorectal cancer, because during the oral interview section, you will be asked certain types of questions. The first is, what is the difference between left-sided and right-sided colon cancer? The second is, what is the etiopathogenetic classification of megacolon? And the three types of intestinal ischemia, which is on the top of your screen. Now, I have left this as is because you can look at this again, and I would like to remind you that in the oral interview section of your exam, you will be asked questions on classification. There are many classifications. There are upwards of, I think, 50 or 60 of them. And you will be asked specific questions based on the classifications. And this is especially true for those of you who are in 60. In 60, and unfortunately, I've noticed this a lot of times, you will be asked a lot of questions, not just about the way you think and the way you would make an operative decision, but why. And the third question is your understanding of classifications, right? So it is very, very important for you to take a look at all of these, classifications wherever they are mentioned. And this goes for intestinal obstruction also, but megacolon's classification is something that I have heard being asked many times. Okay. So with that said, let's go on to the next topic here, which is intestinal ischemia. Now, in intestinal ischemia, essentially there are three things that happen, right? There is a low amount of blood flow. There's a low amount of blood flow. Because of this, there are certain symptoms. Now, the problem here is that you have to try to find out why or what is the underlying cause behind the intestinal ischemia itself. And so we generally define intestinal ischemia more or less within the context of its underlying cause. So, for example, you can have thrombosis, you have arterial thrombosis or venous thrombosis, and arterial thrombosis generally occurs in patients with atherosclerosis, right? So your typical patient would be somebody who's kind of obese and is on heart medication. They may be taking statins for whatever reason, and they may already have ischemic heart disease. So when you see these red signs, in the patient's history, that this patient has got, this patient has a prior history of cardiovascular disease, is on anti-lipid drugs like statins or something, and this patient presents to you with severe diffuse abdominal pain. The issue is that once you see these things, I wanted to connect them both and immediately look for a thrombotic cause. Because the problem with thrombosis is that thrombosis occurs when you have plaques developing in the vessel walls, right? And in the image that you see here, which is of a CT scan, this is the sagittal section, this is the transverse section. In this case also, you can see here that there is a massive thrombosis in the superior mesenteric vein, right? Now, I would like to also tell you one more thing. There is a difference between arterial thrombosis and a venous thrombosis. So you see, arterial thrombosis causes symptoms of ischemia, right? Primarily, that's how they present to the department. However, venous thrombosis leads to portal hypertension. Now, how? You see, the issue here is that if there is a thrombosis, right, blood is not flowing, right? That means the portal venous circulation is getting blocked as well, and you have an increase in portal hypertension. So if you have a patient who has some kind of thrombotic disease, right, von Willebrand factor, any one of these thrombo-occlusive diseases. Second, they may have ischemic heart disease, right? They may have had a prior deep vein thrombosis as well, which would also increase the risk for this. But most importantly, if they show symptoms of portal hypertension in the context of severe abdominal pain, this is what you should be thinking about, that maybe there is no thrombus in the arterial system, it's in the veins, right? So the second thing is that let's talk for a second about embolism itself. Now, embolism, essentially, the reason why we divide thrombi from emboli is because emboli can be of different types. Thrombosis usually are cardiovascular, they are blood clots, right? But emboli are different. You have fat emboli, which are bits of lipids that sort of get released due to some kind of surgery, most commonly seen in hip fracture repair. But the other thing about embolism is also sometimes pneumoembolisms, right? And the problem is that emboli usually travel from one site to the other. So if, for example, this patient had some kind of emboli in the heart, for example, or had a prior history of atrial fibrillation, they can present with an embolus. Now, the symptoms are more or less the same. This patient will also have bloody diarrhea, but the important red flag here is that they may have hemodynamic instability. Now, what does hemodynamic instability generally mean? Hemodynamic instability means that this patient has three major problems. They are either tachycardic, or they are bradycardic, but they have very low oxygen, like SpO2, like oxygen perfusion is very, very low, right? And they may also have some derangements in the biochemical tests that we do, such as, like I say, CBC, with a concurrent problem with maybe sodium and potassium as well, right? So that is essentially what hemodynamic instability actually means. Now, there are two other causes of intestinal ischemia, right? The first one that I would like to also talk about is something called low perfusion. So let's take a look at why you have ischemia. Ischemia occurs again because you don't have enough blood supply to meet the metabolic demands of a certain tissue, right? Now, you can have a block that is going towards this tissue. You can have a second type of block in which all the waste products from or the metabolic end products from this tissue can't leave, right? So that would be a venous thrombus or something, or something in the venous system itself. But the third thing is if the patient just uh, can't produce enough force or blood pressure to be able to carry that blood to meet the perfusion demands, right? So in this case, you have low perfusion in certain types of patients, especially those with heart failure and those with sepsis, right? So because patients with sepsis already have a low blood pressure, they also have a low amount of blood flow, they have increased amounts of venous stasis. The point is that they will result with low perfusion, and this low perfusion can cause uh, intestinal ischemia without a thrombus, okay? Now, this thing is also called non-occlusive ischemic colitis or ischemia, right? Now, non-occlusive causes essentially just mean that this patient likely is septic and has something or is meeting the criteria for SIRS, which is severe inflammatory reaction syndrome, right? Now, the final cause is something called ischemic colitis. So ischemic colitis essentially occurs when there is some kind of underlying infection or inflammatory condition in which the smaller blood vessels that supply the rest of the colon are inflamed or are damaged, and because of this, there's not enough blood flow to the affected colon. Okay. Now, the important bit here is that I want all of you to take a look at how would you differentiate between each type, right? Now, yes, in most cases, you need to do a CT angiography, right? You need to do a CT to understand the blood flow. Second is the value of a colonoscopy is very, very limited unless you see there is evidence of heavy amounts of bleeding. So if the patient has colorectal bleeding, in that case, yes, you would need to do a colonoscopy to try to stop the bleeding at its source. But a CT is invaluable because the CT is going to help you localize the exact cause and location, right? So in ischemic colitis, remember that the smaller vessels are located, and including the marginal arterial Drummond or the arc of Real, right? In acute mesenteric ischemia, right, which is an acute condition, in this case, it's a direct branch of the SMA or the IMA that is occluded, right? Third is chronic mesenteric ischemia. Now, in chronic mesenteric ischemia, you have the same cause, that there is something blocking it, but the timeline of presentation would be different, right? So chronic presentation usually occurs massively due to cardiovascular pathology, right? And in acute mesenteric ischemia, the patient is going to come to you with severe abdominal pain that is not concurrent, or that is not what you would expect with a normal physical exam. The patient is doubled over, they're screaming, or they're just not, they may have altered mental status, right? Now, in chronic mesenteric ischemia, what happens is that this is occurring over time, right? So this patient has had IHD, they're on certain types of medication. They say that they have some kind of generalized abdominal pain, they can't digest food, sometimes they bleed per rectum, but sometimes not. So that is when you would consider that this is chronic mesenteric ischemia, especially if the symptom onset was longer than 6 weeks ago. Okay. Now, the clinical principle, the first thing that I would like all of you to understand here is that acute mesenteric ischemia and ischemic colitis require bowel rest. And the issue is that you have to understand whether this patient's intestines or the colon is either ischemic or infarcting. If it's infarcting, then you need to resect, right? Sometimes there is something that says that, yes, you can insert a stent as well, but that is usually reserved for chronic mesenteric ischemia, because in chronic mesenteric ischemia, the patients don't present with life-threatening problems. So the issue is that with acute mesenteric ischemia, they are presenting to you with shock, with hypoperfusion, sepsis. They may also have a perforation, right? They may have widespread necrosis, and if there is perforation, you will have peritonitis as well. So the problem here is that in acute cases, you will need to open up the patient, something called an exploratory laparotomy, in which you make a midline incision, you open up the patient, you directly see what's going on, and then make the surgical decisions thereafter. But in chronic mesenteric ischemia, you can just do a stenting, you can do a medical management in which you increase the dose of lipids, you can also increase or change the type of lipid they are on, right? So most commonly, if somebody's on atorvastatin, I think the current guidelines say you change them to rosuvastatin. They may also need antiplatelet therapy. So many of these patients could be on aspirin. So you need to switch them from aspirin to clopidogrel. or to prasugrel. Prasugrel is a little better. And you may need to make some other changes in consultation with the cardiovascular specialist. So you need to speak to a cardiologist and make a joint decision together, right? So what I'm going to do is, now that we've covered intestinal ischemia and a bit of the anatomy and everything, before we go on to the next section, right, which is a little bit more important, I want all of you to type down your questions, and I'm going to give you a minute to type out your questions, and I'll get to them in a systematic manner. And I can see there is some kind of question here. Okay, yeah, I'm going to get to your question. Don't worry. So type out the questions that you have, and then I'm going to try to answer. I'm going to give you a minute. Okay. Let's see. So somebody has asked a question. If can portal hypertension also be the cause of the venous thrombosis? Yes. Yes. You see, like, look, let's just take a minute to understand a little bit about our pathology here. Thrombosis occurs due to three things. Either there is a derangement in the blood flow, right? So, for example, maybe the blood doesn't have as many liquid components in it as it needs to, right? Or there is stasis, right? Or there is a hypercoagulable state, right? So hypercoagulable state occurs in a lot of patients who have genetic diseases of the hematological system, so von Willebrand disease or factor IX deficiency, whatever, because the body is going to create more clots, or hemophilia, for example. They're going to not create as many clots as they need to. So there's an increased change in flow. It's called Workhouse triad, right? Now, with portal hypertension in specific, what happens is that there is venous stasis. Once you have stasis, you have the increased likelihood of thrombosis, right? So you are right that portal hypertension can also be the cause of the venous thrombosis, or sometimes the venous thrombosis can lead to portal hypertension. It is a two-way street. Both of these things are interlinked, okay? You can try to determine which comes first, but the problem here is that once you have portal hypertension and the thrombus, the only thing you're going to do is to try to remove the thrombus and reduce the portal hypertension as much as is possible, so that you can have accurate and appropriate flow, right? So I hope that answers your question. Okay, so now we are going to discuss diagnostic methods. Now, I want everybody here to be very, very familiar with diagnostic methods, and there is a reason for this. Your surgery examination, much like any surgery exam in the whole world, right from India to Russia to Ukraine or wherever it is, in America as well, is composed of a practical section, right? And in the practical section, you're not going to be asked to form a diagnosis. You can't form a diagnosis, you're a student, right? But you need to demonstrate to the surgeons in charge that, yes, you know what it is that you're talking about, right? So what they're actually looking for is your understanding of which diagnostic method you would like to use next, right? So there's throughout colorectal surgery, and even in general surgery, in general, in colorectal surgery, however, in specific, we use a series of diagnostic methods, right? Now, I'm going to come here, which is most important in all cases, regardless of whether you're doing surgery or anything. The patient's history is very, very important, right? And you see, there are lots of trick questions you can ask, right? You have a patient who's coming with stomach pain. What is your first step? And people will say, oh, I'll do an ultrasound. No, the first step is take a detailed patient history, perform a physical. And I want this to be the idea that you parrot again and again and again. If you have not done a physical exam and if you've not taken a patient's history, that is what you should be doing first. It doesn't matter if someone else has already done it and they've reported their findings to you. That doesn't matter. As the 6th year students, as the 5th year students, and of course, as future doctors, you are responsible for taking the patient's history and physical again. So remember, your first answer should always be, I'll take a history and a physical again, right? Second, in colorectal conditions, right, there are a few things that happen. First is that there are changes in bowel habit. So what does bowel habit mean? So bowel habit essentially means that the feces that when a patient defecates, what is the frequency of the defecation? How many times do they go to the bathroom? Is the stool liquid or is it solid, or are they having difficulty passing stools at all? That is a change in bowel habit, right? Second, when a patient looks into the stool, you need to ask them whether there is blood and what type of blood it is, right? So for example, if a patient has melena, that means that they have upper GI bleeding. It's somewhere in the upper gastrointestinal tract. But for example, if they have streaks of blood mixed in, or they have you know, they don't have dark stools, but you can see blood clots everywhere, that means that it is a lower GI problem, right? Now, this is especially important because, for example, if a patient has right-sided cancer, the reason why you can understand that this patient may have right-sided cancer is because their stool is very dark, right? It is different from hematochezia, because in hematochezia, you can see blood is coating the stool, right? So that means the stools have formed and then there is bleeding and then the blood is coating it. Whereas in darker colored stools with red blood mixed in with the stools, that means that while the stool was being formed in the ascending colon, there was bleeding somewhere and that blood has got mixed up and then the stool has completely formed and then it is coming out of the rectum, right? Now, the second thing is also rectal bleeding. Now, rectorrhea is a very common presenting complaint, especially here. So a lot of patients will have rectorrhea. They will complain that, yes, doctor, while I defecate, I have bleeding, right? Or I have passive bleeding through the rectum, right? Now, the point is that rectorrhea in and of itself is not a sign for anything. It is not specific enough, but you can start thinking that, okay, if there is rectal bleeding, then maybe there is a anorectal problem, right? So is it rectal cancer? Is it a fistula, hemorrhoids, or is it something else, right? The other thing is that you have to ask questions about dietary intolerance. That means that are they beginning to realize that they are not being able to tolerate certain types of food, or is there do they have an aggravating factor to their disease? So, for example, if you think that the patient is lactose intolerant and they say, for example, have cheese or had a milkshake and then they had severe diarrhea, pain, whatever, then you can suspect that this patient probably has an inflammatory bowel disease, like maybe ulcerative colitis or Crohn's, right? Now, the one thing that you should look for is weight loss, right? Because in weight loss is a red flag for malignancy. So if a patient tells you that, yes, I've lost upwards of 12, 13 kilograms in the last month or so, or maybe even in the last 2 or 3 months, then that means that this is likely that there is a malignancy of some kind. Okay. So in terms of red flags, bleeding combined with weight loss and pain, these 3 things are considered red flags in clinical practice. Okay. Now, once you've done the patient history and taken a physical, one of the things that you should do, which will be in the physical examination section lower here, is to do a digital rectal exam, right? And this thing does 2 things. In men, it is also useful for assessing the prostate, in addition to checking the rectum itself for masses, compressing problems, or for hemorrhoids or whatever. And in men, it's helpful for understanding the status of the prostate. Now, the other thing in physical examination you need to do is to look for peritonitis, which is abdominal guarding. Now, if a patient tells you that even by slight touch, they have a lot of pain, they're bent over and they're screaming in pain, then that means likely there is some kind of peritonitis, right? And you need to also assess the patient for organomegaly, which means both things, liver as well as spleen. Now, I have seen a lot of students make this error here, where they take a history of the patient and they do a very incomplete physical. So when they're looking for changes in the abdomen or palpating the abdomen, they only palpate the hepatic section. They don't do anything about the spleen, and that is unacceptable. And I'll tell you why. In some cases, what happens is that the spleen can be enlarged. Now, an enlarged spleen has a lot of different problems. It could be due to CML. It could be due to other types of leukemia. It can also be because of a splenic artery thrombosis, right? It can be due to peritonitis. It can be due to a pancreatic cancer that is causing a blockage in the outflow tract in the pancreatic system, right? So it is very, very important for you to do a full physical and take a complete history from the patient, especially during the exams. The reason why a lot of people are not successful with their surgery exams is because they do an incomplete physical. And unfortunately, this is something that you have to do as the doctor, and it is your It will be your legal obligation eventually to do a physical yourself. You need to confirm what someone else has said, and you need to check everything out yourself. You need to confirm everything once more if you're seeing a patient again, or even if you're seeing a patient for the first time. So take that principle with you when you go to your practical exams. Okay. Now, let's go to the imaging section. Now, in the imaging section, you have a few options. You can do an abdominal X-ray, you can also do a abdominal CT, whatever. But if a patient comes to you or you see a patient in the ward that has come with rectal bleeding or whatever, please make it a point to answer that yes, you would do a colonoscopy. Now, there's only one reason why you don't do a colonoscopy. That's if you suspect that there may be a perforation, right? But what does a colonoscopy actually give you? Now, if you look at the right-hand side of your screens right now, you will see that a colonoscopy is essentially when you insert this endoscopic camera, and this allows you to visualize the entire colon. And it also allows you to take biopsies, stop bleeding, or to do something called a polypectomy, which is the removal of polyps from the intestinal wall. It will also help you to understand whether there is an inflammatory cause for the current symptoms, or if there is an obstructing cause, which is like a cancer, malignancy, or the polyp itself is obstructing something. And this is very, very important. A colonoscopy is the gold standard tube for colorectal imaging, right? It's sometimes it is even better than doing a CT, for example, because you can exactly see what is going on, and you can sort of you can take measures to to sort out the problem immediately, right? Now, aside from that, you also have something called a barium contrast X-ray. And so what a barium contrast X-ray does, and in this image, you're going to see some polyps, like these small outpouching. They are not called polyps, they're diverticuli. And barium contrast enema, essentially, what it does is that it highlights the bowel wall. So you can see here the layers of the bowel wall itself. So you can see the outer layer and the inner layer, and you can assess here as to what the status of the intestines are. And you can also use this to understand large bowel obstruction. Okay. Now, you can do something called a rigid sigmoidoscopy, and what the sigmoidoscopy does is that it just assesses only the rectum and the sigmoid. Okay. Now, in the presence of a good colonoscopy suite, sometimes you don't have to do this. But in some cases where you are convinced that this is entirely a rectal problem, you can do a rigid sigmoidoscopy to just assess everything around just the rectum and the anal canal. Okay. Now, let's look at imaging in a more greater detail. We have CT of the abdomen, and you can use a contrast or without contrast, right? And the second thing is an MRI. Now, an MRI is considered the gold standard for rectal problems, especially if you have a patient in whom you suspect a fistula, because the tract of the fistula can only be picked up by the MRI itself, not by a CT. Okay. Now, one more thing that you need to know about this is the upright chest X-ray. Now, what does the upright chest X-ray do? A patient is standing up, you take an image of them, and if you see free air under the diaphragm, then that means that there is a perforation, and then you need to plan your operations accordingly. Okay. So the importance of the upright chest X-ray will be relevant to you if you think that this patient may come with a perforation. So remember that the question that is likely to be asked of you is that how do you find out if a patient has a perforated bowel? First thing you do is look at the symptoms, right? Severe peritonitis-like symptoms. Patient is either really sick or screaming, or they may be septic as well. Most of the time it is septic. By the time they come to the hospital, they're most likely septic. And your primary investigation of choice, if you think that there is a bowel perforation, is to do an upright chest X-ray to look for free air under the diaphragm. Okay. Now, with that said, let's go finally to laboratory testing. In laboratory testing, you see the problem here is that the main target that we are looking for in a laboratory testing is to do two things. One, to see if there is the C-reactive protein is very high, or to see the levels of certain types of biomarkers. The most common one we are using right now is CEA. Now, CEA is not a diagnostic biomarker. It helps to understand whether a certain treatment has worked. CRP is more important, because CRP is going to give you the status of whether an inflammatory reaction is taking place in the body or not. And the complete blood count helps you to understand whether there's an infective process, or if the patient has anemia or electrolyte imbalance. So when you're trying to make your final plan for what you're going to do with these patients, you need to be armed with a ton of information. And all of this information comes from one of the 4 diagnostic methods that we use. Okay. So at this point, again, before we go on to the next slide, which is a further detail into diagnostic methods, I want all of you to sit down and try to just give me some questions if something is confusing on. Meanwhile, I'll just change the slide for a second. It has the same information here, but you can see a colonoscopy and a CT of a sigmoid colon. Now, if you have any further questions, please type them in the chat. Okay, so I'm going to assume that you guys don't have any questions so far, which is great. So in this image, let's take a look at this image here. This is a CT scan. And in the CT scan, you can see, oh, okay, there is a question. Why is a CT better than a CT versus MRI? Okay, so an MRI is better in fistula imaging because you can actually differentiate between the different types of structures through which a fistula is formed, right? So the delineation between muscular tissue and connective tissue is far superior in an MRI than it is in a CT. Okay, because in a CT, let's just take a look at what a CT is doing here. This is a CT, right? You can see that this is bowel, there is some kind of obstruction, but you can't exactly see very good specifics of what's going on. Whereas in an MRI, the MRI can actually differentiate between different types of tissue and gives you a much clearer view of what is going on, especially when you need to understand the track of a fistula. So the path that the fistula takes from the external opening to the internal opening, you need to know that so that you can make the appropriate surgical choice, right? So for example, if it's a transsphincteric one, you would do a ceton drain, or if it's an extrasphincteric one, then you would do something else, right? So if you understand the path of the fistula, you can confirm the presence of the fistula as well using an MRI, whereas a CT is not very specific because you can't really make out what's going on. You can maybe make out that, yeah, there is some kind of shadow here, and it's not the best imaging that you can use. Yes, of course, if you don't have an MRI machine, then you'll have to make do. You may have to use something called a fistula probe, in which you insert a very small probe and try to track it, but then that is incredibly painful for the patient. Okay, I hope that answers your question. Okay, so this is the end result of a colonoscopy in which a patient has a cancerous mass, and you can see that this is sort of blocking the lumen, right? So in this patient, maybe they could have had an obstructive problem. The other thing is that if you look at the lumen here, this presence of this cancerous mass is narrowing the lumen, and this can change the shape of the feces that is coming out of the patient, right? That is also something that you need to understand. Now, let's go on to the next slide where we are going to discuss colorectal surgery or rather diverticular disease. Now, let's talk about diverticular disease, right? Now, in diverticular disease, we essentially talk about 2 things. One is diverticulosis and diverticulitis. Now, diverticulosis is just the presence of diverticula. And the presence of diverticula is mostly asymptomatic in most people. And what a diverticulum is that it's just basically a protrusion of it's an outpouching essentially. So remember when we talked about the layers of the bowel wall, what is essentially happening here is, and you can see it on this image, not very well, but you can see it on this image, that the submucosa can go and make a pouch, which you see here, right? So the submucosa and it makes a pouch, and this pouch contains all the layers of the bowel wall. In that case, it's a true diverticular, or it can be a false diverticular in which the submucosal layer, and if you assume that my hand is the muscular layer, the submucosal layer is sort of pushing it like this and creating a outpouching. And this usually happens, false diverticula only usually occur in Hertzsprung's disease, or in some places, or Meckel's diverticulum, in which there are gaps in the muscular layer of the bowel wall, and through which you have diverticula coming out. And the other condition is in the elderly, where the bowel wall's muscular layer loses its tensile strength, and because of that, you can have the mucosa push out, essentially, right? Now, diverticulitis essentially means that the diverticula that you notice have undergone some kind of inflammatory change, and they're completely inflamed, right? Now, in general, you have two different ways of understanding the diverticular. Diverticular pain usually occurs in the right and left iliac fossa. And in these patients, the most common complication that they may come with is bleeding for rectum, right? In a lot of cases, though, you may also have perforation, right? And this perforation can sometimes lead to something called a colonovesicular fistula. That means that there's a connection between the perforated diverticulum in the colonic wall, and this can sort of connect with the bladder. And in these patients, they will have symptoms when their urine has a lot of gas in it. And this is entirely due to the connection between the colon and the bladder, right? Now, Meckel's diverticulum in specific is when we call the vitelline duct, which is a remnant essentially of the fetal circulation. If this remains, this can cause a sort of pouch, like a long pouch, right? And this can itself cause a few problems. Now, from a practical perspective, what happens with diverticular out pouches is that they are essentially pouches. Now, if you look at this image here, in this pouch, you can sometimes have fecal material, right? Sometimes because of the intense peristaltic movement around, it can burst open and be perforated. Sometimes this fecal material that is blocked or lodged in the diverticulum can cause obstruction as well, especially in a patient who has a lot of diverticulum, right? And you have just two major types of investigations. The first is a colonoscopy, and the second is a barium enema contrast study, which you see here. Now, if you look at this image as well, here also you can see that this is a diverticular, and this here is a diverticular because you can see the block here, and you can see this outpouching here as well. This is also likely a diverticular as well. Okay, so if your topic is going to be on diverticular disease, make sure that you mention that diverticulosis is the normal presence of diverticula without any symptoms, whereas diverticulitis is the inflammation of the diverticula. Okay. So do you have any questions so far? If anybody has any questions, let's just take a minute and you can write your question. Yeah, there is somebody with a question. Can astrogafin be used instead of barium? Yes. It's not astrogafin, it's gastrogafin. And gastrogafin is sometimes used. Yeah, gastrogafin is mostly used in the stomach itself, especially when you suspect that there may be a perforation. In the colorectal situation as well, yes. If you have gastrogafin available, you can use gastrogafin as well. So the questioner was asking whether we could use gastrogafin instead of barium. The point is that barium is more specific and gives you a clearer picture. Gastrogafin, not so much. And I think that nowadays gastrogafin is a little more difficult to get in certain countries, but gastrogafin can also be used. The important difference is that gastrogafin can be used in patients in whom you suspect a perforation, right? But it should not be your first line of investigation. It should be the third or fourth. If diverticulosis is asymptomatic, should we just watch and wait? Yes. So if the diverticulosis is asymptomatic, watch and wait and maybe suggest the patient to have a different diet. So diets that are high in fat should be avoided. The diet should contain a lot of fiber, right? And in some cases, you can try to give them like food supplements, although I'm not very supportive of that. You can ask them to increase their level of lactic acid intake. So if they don't have lactose intolerance, then they can have a lot more yogurt, they can have a lot more fruit, a lot more spinach. But beyond that, watchful waiting, nothing. Because a diverticula themselves, they may be concerning, but they don't really do much, right? Unless you have symptoms and you have bleeding, perforation, or obstruction, don't do anything to the diverticula. There's no point. Okay, so do we have any further questions so far? I'm going to just wait for a minute. If anybody has any further questions, you guys can write it in the chat about this specific topic, what we just covered, or something from surgery in general, whatever. Okay, let me see. If a colovesicular fistula is formed, what would be the method of investigation? Good question. A CT is more than enough in this case. Like you can use like CT without contrast. The other thing is that if you do a colonoscopy, you will most likely see the perforated site, and you can also see the connection essentially. But a CT is better because it is non-invasive. Remember that in cases of perforation, try to go non-invasive in terms of the imaging that you try to do. So a CT is better than doing a colonoscopy, right? Because colonoscopies require you to insufflate the colon. So that means that you will be inserting saline or something to sort of expand the colon so you can fit the colonoscope in there. So in terms of if you think that a patient has perforation, then in that case, just try to go for CT, MRI, or maybe a gastrographin study. But gastrographin studies are just, I would not advise a gastrographin study in perforated patients. It's better to just do a CT. A CT will give you enough information about what's going on, and then you can just do an open laparotomy to explore and fix. Most cases of perforation, you will need to open up the patient to an exploratory laparotomy and then just fix what you see here. There are some, there is some evidence to consider that, okay, in some types of perforation, they can heal spontaneously, but I don't think so. And so far, from what I have seen, which is very limited, of course, but perforation need to be fixed immediately. So it's important to open up the patient, see, identify where the perforation is, and fix. And the best thing at your disposal is most likely a CT. Okay, so we are just going to go on to the next topic here, which is polyps. Now, polyps, they are outgrowths of the colonic mucosa. So the mucosal layer sort of grows out. And you can see this beautifully in this image here and in this image. This is also a barium contrast study. And what the barium contrast study has done is that because what barium does is that it deposits on the mucosa, and the follow-up barium, you do it in two shots. The second shot sort of, like the first shot, like goes into the intestinal wall and gets absorbed a little bit. And the second one just goes over it. So what happens is that you can actually see the wall of the intestines because of this. So for example, like in this patient also, you can see that the hostra and the different sort of sections of the colon are present, and the wall can be seen very well. And in this case, this is the polyp here, because this is an outpouching and it's coming out this way, right? And we normally we don't normally talk about polyps in two terms, which is benign and neoplastic. Although some polyps can become neoplastic, like adenomatous polyps, which is something we're going to just discuss as well. But most polyps are generally benign, right? At the most, they may come with bleeding or ulceration, and sometimes they may come with obstruction. And in patients, if you think that this patient has a polyp, your first idea is to do a biopsy to look at it and send it to the pathologist who can tell you what type of polyp it is, right? And you can have inflammatory polyps, which can sometimes increase the risk for cancer, but mostly it is hamartomas polyps. And sessile serrated polyps don't really have very good neoplastic potential. Hyperplastic polyps almost don't ever cause malignancy. They are called hyperplastic because a lot of them, they cause perforation, they cause obstruction more than malignancy. The basic neoplastic type, which is the most common neoplastic, the most high risk for neoplasia is through the neoplastic polyps, and that's through adenomatous polyps. And I think in the next slide, I may have put an image and we'll discuss it a little bit further there. Now, when you look at a patient with endoscopy, your first line of treatment is going to be a colonoscopy. In this case, you can see whether it is sessile, flat, pedunculated, or depressed. And there is an image where you'll see what I mean by all this, but right now just remember this. And for the exam, remember the endoscopic classification. Management is usually polypectomy. If the polyp is really large, like upwards of 10 millimeters or something, then in that case, yeah, just get rid of it. Otherwise, most of the time, small adenomas are like small polyps, don't need anything. You just leave them as they are. Okay. Let me see, there's another question or something. Okay, I will answer your question at the last. Yeah, I think it's a good question. I'll answer it. So here, what the thing is that let's go on to the next slide here. And when you look at the polyps themselves, you can see here that polyps can transform into adenomas, right? And this is called the adenoma carcinoma sequence, which is our next, which is going to be in a couple of slides from now. But when I look at a polyp on the colonoscopy, this is the kind of uh, uh, this is the kind of descriptor we have to use. So one is a protruded, so it's called pedunculated. It has a stalk and a bulb. This is subpedunculated, that means that it doesn't have a stalk. Superficial can be both elevated and depressed type. Flat is when there is a change in the mucosa. The mucosa is thick, but it's not really going into the lumen wall. It's sort of flush with the wall of the wall of the bowel. And then there are depressed types, right? And here I want you to understand one thing about polyps is that they may have a degree of hyperplasia. So when we look at the polyp and we send off a biopsy, we need to look and see whether it has a very high grade of hyperplasia, and then we can do the next step, which is managing the polyp. So we have two ways of managing the polyp. One is either we don't do anything and wait and watch, or the second is to just do a polypectomy. That's pretty much it. Okay. Now, the point here is that in polyps, the most important thing that you'll be asked about is called adenomatous polyps. So adenomatous polyps are these are the most common neoplastic polyps. So in this case, you can see here that there is a stalk, and it has a tubular adenoma. Like the adenomatous, it's called adenomatous because it's forming small adenomas, and these things are what can form the foundation for causing cancer. The foundation causing colorectal cancer. And we define adenomatous polyps through two ways, essentially. One is its classification based on size. The second is a histological classification. And the one important factor is that you need to know whether it has low-grade dysplasia or high-grade dysplasia. High grade of dysplasia is worse than low grade, right? And again, you could use the same endoscopic classification. But let's talk about management. The point is that you have a polypectomy, right? So what you can do is that if it's a very small one, when you take a biopsy and you see and confirm that, yes, this is likely an adenomatous polyp, in that case, you need to remove it, regardless of what stage it's at. Because the point here is that the fact that we have to remove it is sure. It's just that the method that we use to remove this polyp differs, and it largely depends on the size at which you find it. So, for example, if it's a very small polyp, like this one, just the biopsy forceps most likely are enough to just get rid of it, right? Then you have a snare resection for those that are larger, like for example, this one or this one. As long as it has a bit of a stalk, you can sort of, the snare thing is that you use a wire to sort of capture the base and just cut it off and take it off, right? You have en bloc resection, in which you just remove everything all around it. You have a resection margin of say 2 or 3 millimeter. So everything around it is removed and taken out. And then of course, if you have high grade dysplasia, then you need to consider that this patient might have colorectal cancer. So in that case, again, you need to stage the disease appropriately. And then you need to do a follow-up colonoscopy after like staging and removal. So the thing is that your polypectomy is the same, that the procedure of removing the polyp is the same. It's just that the type of tools we would use are different depending on the size of the polyp as well as its likely histological characteristics. Okay, so I hope that this is clear so far. Again, if you have any questions, you can ask me. Okay, so I'm going to assume that there are no more questions so far. Let's now go into something more important, and this is a very important thing that you need to understand. This is called the adenoma carcinoma sequence. Now, I would like all of you to take a minute to note this down somewhere and make sure you study this for your exam. This is for whether you're in 5th year or in 6th year. So essentially, an adenoma carcinoma sequence is the term we give to the sequential turning from the normal epithelium all the way to a cancer, right? And most of the time, what happens is that you have adenomatous polyps that undergo changes, right, and become cancer, right? So what is happening here is that first you have normal epithelium, okay? Now, in normal epithelium, because of some reason, you have APC inactivation. So APC is called adenomatous polyposis colony. This is a type of tumor suppressor gene, okay? So this gets inactivated. And once this gets inactivated, you have a small benign polyp. Now you have something called CRAS. So CRAS is a type of um, tumor promoting factor, essentially, or an oncogene or proto-oncogene, most likely. What happens is that once CRAS becomes active and becomes an oncogene, this large benign polyp, starts to become even bigger, right? And it can start having dysplastic change. Okay. And once this transformation to a larger benign polyp is there, and then it starts continuing to grow, there is the inactivation of DCC, which is a tumor suppressing gene. So if DCC is stopped, this thing goes into a uncontrolled growth. And then finally, the last gatekeeper is called P53. So when P53 gets inactivated, you have a malignant tumor or this cancer here. Now, one thing you must remember is that this entire process takes upwards of 10 to 15 years. And currently, our aim is to try to find it at this small benign polyp to understand whether a patient with a small benign polyp needs a resection or they need to be enrolled in a specific screening program. And the purpose of a screening program is to try to catch a disease early so that it can be managed earlier before it becomes something difficult to manage like a malignant tumor. Okay. So remember that if you're going to try to understand the adenoma carcinoma sequence, remember that normal epithelium, because of APC inactivation, becomes a small benign polyp. And then the small benign polyp, the cells there undergo CRAS activation, which is the activation of a proto-oncogene or the activation of an oncogene. And then that becomes a large polyp. And then the subsequent inactivation of further tumor suppressing genes like DCC and P53 is what causes the development of carcinoma. And the thing is that there is, when we go to colorectal cancer, we'll understand some things about genetic or hereditary cancer. So in familial adenomatous polyposis, there is the individuals there or patients with FAP, they usually have an inbuilt or a congenital cause for the inactivation of APC. Whereas in normal people or like people without this gene, it's likely due to smoking, elderly age, things like that. Okay. So once you've understood this, if you have any questions, you can ask me now, and please type them in the chat, and then we'll go on to the next block, essentially, which is just colorectal surgery, which is vastly more important, it's very, very important for you to understand colorectal cancer itself and the types of operations that we do, because a lot of your questions are going to come from that. So if you have any questions so far, if something is not clear, please, just sort of type it in the chat. Okay. Yes, so DCC and P53 are tumor suppressor genes. They act to suppress tumors. And if they are inactivated, the tumor just undergoes transformation into, say, hyperplastic to completely neoplastic. I hope that was clear. Okay. I'm glad to be here now. Okay. Does anybody else have any further questions? Okay. So I'm now going to move on to the next section. And we are going to talk first about large bowel obstruction, which is something you will see in patients with cancer as well. So large bowel obstruction essentially, is when there is something that is blocking the outflow tract of the bowel, right? So what happens is that there is something that is, present within the lumen or outside of the lumen, whatever, and that is causing the complete obstruction of any fecal matter from passing. Okay. Now, clinically, a patient with this disease is going to come to you. With abdominal distension, altered bowel habit, maybe constipation, right? Or the stools are going to be of lower caliber, right? They may have sepsis, bacteremia, and possible perforation. Now, let's imagine it this way. You have a tube, right? And from one end, there is water going from one side to the other. If you block this tube or this pipe at the area before the blockage, that is what you call the proximal site of the obstruction. So this area, which is before the obstruction, is called proximal obstruction, or the area proximal to the obstruction. And anything that comes after the obstruction is called the distal end. Now, in the intestine, what happens is that once you start having a lot of impaction and there is something that is blocking it, blocking the outflow, intestinal obstruction essentially causes the entire intestine to sort of swell up, right? It swells up, the bowel stretches and stretches and stretches, and then you have either perforation or the interesting thing here is, and this is why I insisted that we spend a minute studying the layers of the bowel wall. When this stretching occurs, all of the blood vessels gets crushed and pressed close. And because they're getting crushed, what is happening is that all of the fecal matter that is present here with the bacteria and everything finds it very easy to pass into the blood vessels. And as this obstruction sort of increases and this increases the intraluminal pressure within the intestine, it makes it far more easier for materials, chemicals, whatever, to pass from the bowel wall right into the blood supply. And a lot of times, a patient with large bowel obstruction may come to you extremely sick with a lot of bacteremia, and they may be septic. And this sepsis may not be because of a perforation, but simply because all of that fecal matter is present now in the blood, right? Because from the fecal matter, there's lots of bacteria, and this can enter the blood and then cause infection, widespread systemic infection. Okay. Now, the point here is that there are different causes for it. The one is colon cancer, most common, right? After that, you have diverticular disease. Okay. And we discussed this previously. And then intestinal volvulus. Now, intestinal volvulus is just the rotation of the intestine on itself, just like stomach. And intestinal volvulus occurs because of a lot of different reasons. It's not important to go into those right now. But one of the most common causes of intestinal volvulus is essentially because there is a tumor that can cause it to twist on itself. It can be a bowel injury, a prior surgery, or maybe one of the adhesions from a previous surgery has lifted and broken, and then that can cause the bowel to twist on itself. Now, you have two options for imaging. You can do an abdominal X-ray or a CT abdominal pelvis. Notice that I'm not written a colonoscopy. And why is that? That is because a colonoscopy will have zero value in a large bowel obstruction. You can't do anything with a colonoscope. A colonoscope, it's too small. You won't even be able to pass it. And the point is that, again, like I said, if you have an already distended bowel, if you try putting more material like an insufflating agent like saline water, argon gas, whatever, you run the risk of massive perforation. Okay. So for that, it is very important that if you see a patient who has abdominal distension, altered bowel habit, maybe has sepsis, try to do a CT of the abdominal pelvis. And if you can't do that, just do an abdominal X-ray and you will see it here. And the abdominal X-ray, you can see that there is an obstruction cutoff point here somewhere, which is here. And here you can see that there is a massive amount of obstruction. What exactly the obstruction is that I'm not being able to see, but it could be anything. And you can see the major difference is that this intestine is really large and wide, and suddenly it drops off and becomes small. That means that the obstruction is here, and this area is distal to the obstruction. So that means that this area is normal, or maybe sometimes it can atrophy as well. And you have this area that is sort of wide. Okay. Yeah, there are some questions here. Okay, so somebody it's a very good question. Thank God, very nice of you to ask. So let's go again as to why this is large bowel obstruction and megacolon are different. See, megacolon essentially occurs when there is a lack of peristalsis, which causes the muscles to sort of relax and keep going forward, right? There is no peristalsis. Large bowel obstruction, you will still have peristalsis, right? And megacolon can, yeah, you are kind of right that yes, technically you could call it a functional adynamic spastic bowel obstruction, but the problem is that there is no material that is blocking it in megacolon. In a megacolon is just that the intestinal contents just become wider and wider, and they can be passed out. There's no, in large bowel obstruction, largely there is no fecal movement. So you may have sepsis and constipation, whereas in a megacolon, that's not always the case. And the only reason we don't call it an adynamic spastic bowel obstruction is because there's nothing really obstructing the bowel if the bowel just doesn't work, right? And the other reason is that, yes, sometimes you have this idea that sometimes, look, in some cases, it is possible for a megacolon, right, and an intestinal obstruction or large bowel obstruction to occur together, but they are two different things. The point here is that a large bowel obstruction in general, what we mean by large bowel obstruction is that something is blocking the outflow tract, right? Whereas in a megacolon, that's not the case. In the megacolon, what happens is that you have some reason why there is no peristaltic movement at all, right? Now, the second question is, if for example, we do say that megacolon can be caused due to a spastic ileus sort of situation. The point is that spastic ileus comes from an external cause, and that's usually because of chemical use, or like maybe this patient had too much morphine, or they may have had some kind of poisoning. That is why it will also happen. So in paralytic ileus, there is no bowel obstruction. So what is the difference? So paralytic ileus is a condition. It's not a symptom or anything. A paralytic ileus occurs mostly in post-operative patients because of the use of anesthetic drug. So these are different surgical conditions. Large bowel obstruction is a condition of which you need to find the cause. Megacolon is a condition in and of itself, right? Number one. Number two, it doesn't always have an outflow obstruction. So a megacolon can occur with an empty megacolon as well. It's just that it's just wide and large and still perforated, right? In obstruction, you see the key word here is the obstruction bit. The obstruction part is that there is something that is present within the intestine, whereas in a megacolon, that is not always the case. A megacolon is just that the colon just starts widening for no reason. It may have something in it, it may not have something in it. And even if it does have something in it, that is not the cause of why it's becoming large. Essentially, it's a causative difference. You understand? Now, in realistic terms, it may not make that much of a difference. In both cases, in large bowel obstruction and megacolon, you will have to remove the entire section out of the way. So that is this is like a theoretical difference between megacolon and all that. The other thing that I can see is that in megacolon, you have something called toxic megacolon. That means that there is the fecal contents are started spilling into the peritoneum. There is patches of infarction and gangrene in megacolon, and so that is toxic megacolon, and that in that case you need to remove it. Well, the thing is that the end result is that you're going to have to remove these bits of the intestine anyways, right? Okay, yeah, that's answered your question. Good. Could it also cause perforation? Yes, I'm assuming that large bowel obstruction does come. So large bowel obstruction eventually can cause perforation. That's simply because like this, for example, in this patient, I wouldn't say that they had a obstruction, but I can't they had a perforation. But what is happening here is that the thing is that look at there is something in here that is sort of expanding it, right? And that can cause the bowel to perforate. Okay. The management of this is that you can do a colonic stenting. Now, in a megacolon, the point is that a colonic stenting can be used just for drainage purposes, right? In large bowel obstruction, it does two things. It causes decompression as well. So in this, in such a patient, for example, so this patient has large bowel obstruction. When you do a stenting, what you're doing is you're decompressing it and bring it down to size. In a megacolon, that expansion is sort of permanent. So you can do a decompression and just remove everything and then you can resect. But the thing is that most of the time you shouldn't wait that long in megacolon. The second thing is that, look, you have two ways of decompression, right? You can do a NG tube and suck everything out from there. So any food material, anything that the patient may have eaten, you can remove that. And so it can cause it can remove anything from going into the bowel. The second is the rectal tube decompression. So there is a rectal tube that is passed into the rectum, and that helps to remove all the feces. Now, this is exceptionally important if you have an obstruction, maybe in the rectal canal, anal canal, something like that. And you can go past it, then yes, you can put a rectal tube as well to sort of decompress the bowel that has a lot of feces in it. But the surgical resection part is more or less done all the time. Like even if you try to, in some cases, like there's something called pseudo obstruction. So pseudo obstruction occurs when you have obstruction-like symptoms, but that's because the patient doesn't have a very good, the patient doesn't have a very good peristaltic function. And what happens in that case is that in pseudo obstruction, you will have some amount of fecal matter that will still come out, right? And it's called pseudo obstruction because it can be managed entirely medically. You give them something called lactulose. So what lactulose does is that it increases peristaltic motion as well as increasing the rate of contractions within the intestine. So it allows the bowel to sort of function and push all the fecal matter out. Otherwise, in this case, and you can also give you can give something like a cathartic or something, which helps to clean out the bowel by the increasing the nervous activity of the Meissner or back plexus to sort of increase contractions and peristaltic movement as well. But in general, trying to manage a bowel obstruction, first do an imaging, look at what you can see, and then you may have to just once you open up the patient through a laparotomy, you look and see for signs of peritonitis, signs of perforation, and manage accordingly. So most of the time, you'll do a surgical dissection and remove the entire bowel, or like remove segments of the bowel depending on where the obstruction. So I hope that has answered all of your questions. If you have any further questions, please just type them in the chat. So someone has asked whether if with fecal impaction, lactulose is okay or not. So clinically indicated, right? See, with fecal impaction, what has happened is that this is something called a fecolith. So fecolith is basically a stone that is made out of fecal material, right? And in fecal impaction, that's largely the what is causing the impaction in the first place. So lactulose is not going to do anything. You'll have to do something called manual decompression. So, or it's also called fecal disimpaction. So depending on whether at what level it is, you may have to manually remove it and scoop it out, right? Or you may have to like cut open an area, like make an incision along the bowel wall and open it and then suck everything out using like a suction tube or something. But most of the time, lactulose is not going to do anything. It's like it's going to cause the patient more pain for no reason. Okay, yeah. Like, see, when you have fecal impaction is separate from just an obstruction as well. So in a pseudo obstruction, what happens is that you don't really have fecal impaction per se, you just have fecal stasis. Let's look at it that way. So what lactulose does is to allow that movement to be more smooth. It also allows that movement to be to take place in the first place. Now, in fecal impaction, what is happening is that the feces are impacted in one place, they solidify and they form a fecolith, so which is like a very hard mass of feces, like it's very hard. And so in that case, the lactulose won't do anything. And in what happens is that if you have a very strong mass and you got constantly there is some kind of peristaltic movement around it, it will just going to cause the patient a lot of pain. So you have to be careful when you prescribe the lactulose as well. So with that said, let's go to colorectal cancer. So colorectal cancer essentially is a type of cancer that is found anywhere between the ascending colon, transverse colon, descending colon, sigmoid colon of the rectum, right? And on your screens now, in the clinical features section, you are going to be asked this question. I guarantee you this. What is the difference between a left-sided cancer and a right-sided cancer? So left-sided cancer is essentially a cancer that is present on the left side, which is the descending colon side. And when you look at large bowel obstruction, most of the time, patients with left-sided cancer come to the hospital because they have obstruction. Right-sided cancers don't generally cause obstruction, and when they do cause obstruction, that is like very, very aggressive and a very large tumor. Most of the time, the main difference between left-sided colorectal cancer and right-sided colorectal cancer is that left-sided colorectal cancer patients will come to you with obstruction, whereas right-sided colorectal cancer patients come to you with anemia and altered bowel habit. Okay, this is the most important part, and I want you to study this section and prepare and just memorize it, understand it, and answer this to the professors. Now, in colorectal cancer, we technically look at two things. One is a risk factor, one is a direct cause. Now, risk factors are those things that can increase your risks for getting cancer, right? So it is smoking, elderly age, male gender, people with a Western diet, because Western diet has very low fiber, and low fiber intake in general. And here's the catcher. If you've had inflammatory bowel disease before, ulcerative colitis or Crohn's disease, in that case, your risk of developing colorectal cancer is higher than those who have never had the disease, right? Now, when we talk about direct causes or causes, right, we talk about patients who have diet and risk factors, and those people are 75% of the cases, right? But however, in 25% of the cases, they have a genetic predisposition to developing colorectal cancer, right? So one of the most important things is that in genetics, there are from a genetic perspective, there are two different diseases. I mean, they're not really diseases; they're a collection of diseases, but we call them two different diseases, right? So the first is called familial adenomatous polyposis, which is a genetic disease in which patients they just develop adenomatous polyps, right? And these patients are usually younger and they have a genetic cause for this entire adenoma carcinoma sequence that we just told you. And the second is something called Lynch syndrome, which is hereditary non-adenomatous colorectal cancer, or it's actually called HNPCC, which means hereditary non-adenomatous polyposis colorectal cancer. That means that these people don't have polyps per se, they just directly develop the cancer itself. Now, in Lynch syndrome, the one thing that I would like to remind all of you that is different is that in Lynch syndrome, the cancer is not just in the gastrointestinal tract. There can be a cancer in the breast also. It can also be a primary liver cancer or a cancer in the stomach or in the uterus. So the point here is that the only difference between people with FAP and Lynch syndrome is that the primary cancer could be from somewhere else, right? And that could be a Lynch syndrome cancer, right? Whereas in FAP, most of the time they have just a colorectal cancer, right? So that is the basic difference. Now, again, we'll just go through the adenoma carcinoma sequence, which is first is the inactivation of APC, activation of KRAS, right? And then the inactivation of P53. This adenoma carcinoma sequence has to be written down in your essays in two places. First, if you have polyps as your topic, and the second is if you have colorectal cancer. Okay. Now let's go on to the next slide here. So the next slide is we are going to just talk about colorectal cancer in and of itself, right? Now, colorectal cancer is one of those cancers that is the success of surgical oncology, that is surgical resection, is the highest in this case, right? So that means essentially that for most patients with colorectal cancer, we're going to just operate. Now, what kind of operation we do depends entirely on where the tumor is located, right? And on its staging. So in this slide, you're going to see two areas of staging, right? One is the TNM classification, which is classic TNM 1, 2, 3, T1, T2, T3, T4, N1, N2, M1, M2, right? But when we look at, there's a very important type of staging called Duke's staging. Now, what Duke's staging does is that it essentially divides patients into 4 types based on their level of survival at 5 years. Okay. So it's taking actually a lot of different factors into account. And what it does is that this is used for its Duke's classification is for rectal cancers, which we discussed last time, as well as colorectal cancers. That means all of the colon as well. So I want all of you to focus on Duke's classification, which is what we're going to discuss right now, right? So type 1 are those types of cancers which are limited to the muscularis mucosa. That means that they're just submucosal or mucosal masses. They can be cleared out, extricated, removed, that's it, okay? And these are like a really, they have a 93% survival rate at five years, right? Now, in type B, what happens is that the muscularis mucosa is now being sort of penetrated, right? And the degree of penetration subdivides B. And in these patients, it's around 70%, the 5% survival. When you go to type C, there is lymph node invasion as well. And so that brings down your survival to 30 to 40%. And then type D is when you have a distant metastasis. So distant metastasis essentially means that there's 5-year survival rate could be anywhere between 10 to 15% or 10 to 25%. Okay. So that is what you need to understand about Duke staging. Now, I can give you my word because this is going to be recorded. At least one of you is going to be asked Duke staging. So I want you to put a lot of focus into understanding Duke staging, and so that you can write it down. Duke staging, remember, is also used for rectal cancer as well as colorectal cancer. Okay. Now, from a chemotherapy perspective, we give these patients FOLFOX4, which is done as adjuvant therapy right after the surgical management, because surgical management still happens to be the best and the only way to treat colorectal cancers, right? And we also do something called post-operative follow-up, so in which we assess the amount of CEA that is circulating in them. We do it every 3 to 4 months. for the first year, and then after that, it goes to every 1 or 2 years. Okay. Now, in this case, your imaging of choice is always going to be a colonoscopy and a CT abdomen. You need to combine both. If you think that this patient or any patient has a colorectal mass, do both. Do a colonoscopy, take a biopsy, and then do a CT abdomen, right? Now, in CT abdomen also, you have different types of new CT materials, like it's called CT angiography or like a 3D reconstructed CT. Those are really fun, but you can do your research on that. And they are very helpful as well because they give you like a very three-dimensional, like highly detailed map of the body and the tumor and with the exact resection margin, right? But in general, remember from the principal perspective is that you need to do a colonoscopy and a CT abdomen. That is something you have to answer as well. The professors want to hear the word colonoscopy. When there's a colorectal cancer topic, please say colonoscopy, with only one exception, if there is perforation, right? If there is perforation, no colonoscopy. If you think that there is a massive obstruction, no colonoscopy. Otherwise, everything else for investigating any kind of rectal cancer or rectal bleeding, colorectal bleeding, blood in the stools of any kind, colonoscopy. Okay. Now that we've covered this part, right? Let's go on to the surgical management. Okay. Now, the toolkit of the surgical oncologist and the general surgeon when dealing with colorectal cancers as well as colorectal masses and colorectal problems are first these three operations that you see on your screen right now. Okay. So the first one is called the right hemicolectomy. Now, the right hemicolectomy is something that you need to know because even as a CT1 doctor, you might be asked to perform it, right? It is a very common surgery and it is also technically very easy to do. Now, what happens in the right hemicolectomy? In the right hemicolectomy, what happens is that we take part of the ileocecal valve, right? This part. We take the entire ascending colon roughly at the level of the splenic flexure, the hepatic flexure, right? And we just remove it. Okay. Now, this is done for all the tumors that are present in the ascending colon. If, for example, you have a patch of necrosis here, then you need to do this surgery. Okay. And in this case, if you have any damage, intestinal ischemia, massive perforation, an obstruction that is somewhere here and it's caused like, bowel gangrene, then if it's limited only to this, the ascending colon, then you will do a right hemicolectomy. So remember, right hemicolectomy is not just a surgical oncology procedure. Like it's not just for colorectal cancer, but it is also for other colorectal diseases as well. Now, there is a difference. Now, when, for example, if I have a tumor somewhere in the transverse colon up here, for example, in that case, I do an extended right hemicolectomy. Now, the thing about the extended right hemicolectomy is that because all of these things have the same blood supply, I will have to remove them all because the risk of tumor seeding is too high. So, for example, I can't just cut only this small part and then reattach it. It's not going to work because the point is that there can be tumor mass spillage, and also because when you try to make an anastomosis between these two ends, sometimes it just doesn't work and requires a lot of. It may require a lot of revision surgeries to ensure that the anastomosis stays secure. It is always easier to do an extended right hemicolectomy. Then you will bring the remaining part of the ileum and up into the remaining part of the transverse colon, where you do an end-to-end anastomosis. Earlier, they used to do an end-to-side anastomosis like this, but nowadays they've understood that it's better to do an end-to-end one, especially because now we have something called GIA staplers. So the stapler will sort of create a very strong seal, right? Instead of manually cutting and opening and doing this and doing an end-to-side anastomosis, right? Now you have the left hemicolectomy, and this is for any tumor that is past the first half of or it's a part of the distal 1/3 of the transverse colon, all the way down here to the descending colon, where it becomes a sigmoid. So if I have any tumor, any damage, any perforation, whatever, in this case, I would do a left hemicolectomy. Okay. And what happens with the left hemicolectomy is that the transverse colon gets attached to the sigmoid colon like this. So you can see the anastomosis done here perfect. Okay. So we've done three major operations. Let's let's get some questions out of the way because I can see. Is there any case in which Hartmann's operation? Yes, yeah, like Hartmann, that's not, see, the problem with the Hartmann's is that Hartmann's is also called a low anterior resection. So low anterior resection is for those that are in the sigmoid, right? So for when we talk about left-sided colon cancer, we divide them into two types, which is going to be seen on this image that I put on the screen right now. You have those tumors that are present in the splenic flexure or in the descending colon, and then the separate ones for sigmoid and a separate one for and a separate one for tumors that are present within the rectum. Yeah. Okay. So for the left and right section is on the right hand side, anything that's on the right side, that is ascending colon, transverse colon, that's through the superior mesenteric artery, right? And on the left is through the inferior mesenteric artery. Okay, that is the difference. Now, is there for example, in Hartmann, look, there is one emergency. So when you're talking about colorectal emergencies, one of your emergencies is going to be penetrating wounds to the intestine. Someone gets stabbed, for example. Now, if, for example, you need to do a resection, it is always important to try to remain or maintain as much bowel continuity as is possible, right? So when you're trying to do bowel continuity, it is really, really important. Just 1 second. I'm so sorry. There's a small issue. Yeah. Look, in a Hartmann's procedure, what you're doing is you're removing the rectum and the sigmoid, right? And the left-sided cancer could be anything between present here all the way down to here, right? So you do Hartmann's only if it is present somewhere here, or if, for example, there is some kind of blast injury, for example. Like, for example, there was a case that I had read from someone I know who was deployed to Afghanistan. I was a doctor, and there was a blast injury, and a lot of shrapnel went into the patient's. The patient had either turned or was behind or was in front of this explosion, and there was massive penetrating injury all the way to the rectum and the sigmoid and the anal canal. So in that case, you would do a Hartmann's, which is basically a complete resection of the rectum and the sigmoid. Okay. It is also called a low anterior or an ultra low anterior resection, which essentially means that you would remove part of the sigmoid colon, right? And this is what a Hartmann's is. Okay. So when you talk about a Hartmann's, what you're actually talking about is something called an anterior resection. Yes, and the colostomies can be reversed as well. In most of these patients, we try to reverse the colostomy, right? So in all of these cases, so for example, you will do a ileostomy first, let the rest of or you do like a temporary colostomy, and you let the rest of the remaining bowel rest for like 2-3 weeks or maybe up to a month. And then a month later, you go back in and like do the colostomy again. Now, we do this in 2 stages, essentially. The first is the resection part, and then you end with a colostomy, right? Or an ileostomy, depending. And the next stage would be reversal of the colostomy. So that's usually done after 4 weeks because it allows the rest of the bowel wall and everything and the peritoneum and everything to rest and not be so hyperactive and completely sort of be stable so that we can again open up everything and then reattach everything. Now, in some cases, of course, like there is something called the abdominal perineal resection, in which that is a permanent colostomy, and an abdominal perineal resection is this one, in which we basically remove everything from the sigmoid colon all the way down to the rectum and the anus and the anal sphincter and everything. And whatever is remaining here is brought to the surface or the abdominal wall and left there as a permanent colostomy. Okay. So I hope that answers all of your questions. See, in the anterior resection, you see, you are doing this here. You're removing parts of the sigmoid and the rectum, and then you bring this down and connect it together. Okay. Now, the thing is that you can do this immediately if there is not much risk. The patient doesn't have any like rectal illnesses or anything, but sometimes you'll have to wait. And this remaining part that you leave is called the rectal stump, and you do a stoma reversal procedure afterwards as well. Okay. So now that we've understood this part, we are now going to go into just this surgery based on tumor location. So we have already discussed this, right, in the previous one. Here, I just want all of you to take a look at this. It's not just tumor location. Sometimes based on perforation location, or if it's some kind of damage, you the similar. You can do similar surgeries. Now, here I want all of you to look at this thing called a pan total proctocolectomy. It's also called a pan proctocolectomy. This is the entire removal of the large intestine, including the rectum and the anus, right? And this is done in patients with very, very severe ulcerative colitis, with a lot of bleeding and a lot of intramural damage, and there could be perforation and nothing actually remains. So in that case, you have to remove all of this, and that's called a total proctocolectomy, right? And this is a very rare surgery. It's usually done in patients with like completely incurable or unmanageable ulcerative colitis, right? And this is something that you need to know. You will have to ask. You will have to try to remember this this slide, okay? Because you will be asked about different procedures. So for a right-sided cancer, you do an extended right hemicolectomy or a right hemicolectomy, right? These two. For a left-sided one, that is here, it depends on the location. You have different options. You can do a left hemicolectomy in which you just remove parts of the thing, parts of the transverse colon, the splenic flexure, and the descending colon. Or if it's lower, then you do an abdominal perineal resection. Now, all of this has been given to you based on tumor location. I want all of you to pay attention to it. I'm so sorry. Yes, I want all of you to remember this thoroughly, go through it, and I want all of you to take your time to understand three things: tumor location, the type of procedure that is done. That's it. Tumor location, type of procedure. This is why I created this chart. If you have a topic that is in colorectal cancer, there are a few of them: colorectal carcinoma, then common surgical procedures, I think topic 90 or something, whatever, doesn't matter. If you get a topic in colorectal cancer, as long as you know this slide itself, right, what different operations do, then you are through. And here I've also given you the steps to each of them. And you can understand this, and you can take a look at the images here and the images at the back. One of the most important images is this one, because it actually tells you the different limits, essentially, of what a right hemicolectomy is, when is it considered a right extended hemicolectomy. If you want, for your exams, you can draw this image as well and present that to the professor. Okay. This is what I did for my exam as well, because I was also asked colorectal cancer, and this is what I did. So, and I got a 6. So anyways, with that said, we have come to an end of